Just 2 seconds. Good evening, esteemed colleagues and members of the Pharmaceutical Society of Kenya. Welcome to tonight's CPD accredited webinar. As we wait for more of our colleagues to join in, feel free to type in the chat where you're joining us from. We'll give a minute just to get the feel of the room. Last time we had someone from Isiolo. I'm very curious. Karibu sana Daniel from Utawala. Welcome everyone. Maybe as we engage on the chat, Karibu Venisha, such a unique name from Nairobi also. Vitalis, Nairobi West. I see my audio is clear. You can hear me. Alexander from Matu, Karibu sana. Ayub Obare, all the way from Siaya. So it is 5 minutes past the hour. I don't want to take much of your time. I promise you we will not be here up until 10 p.m. so that you can watch France versus Spain. Allow me to share my screen. If you can see my screen, drop a thumbs up. Awesome. I see Jacqueline is very keen on CPD points. Don't worry, I will brief you on how to go about it. Good evening once again. Tonight we are privileged to partner with MSD to dig deep into the evolving role of pharmacists. Remember, at pharmacists, we are no longer just sitting on the sidelines. We are on the front line, first point of contact with the patient. And our topic today is the evolving role in adult female vaccination against HPV-related cancers and other diseases. Just a reminder that we went to school, we are the educators, advocates, and increasingly, pharmacists are being identified as key players in the role in immunization to close the gap, especially in adult preventive care. Tonight we will explore on clinical burden and just before we proceed, I would like to lay down a few ground rules, which I believe by now we already know that you will be muted during the entire course of this session. If you have a question, feel free to type it in the Q&A tab. Reserve the chat section for general remarks and interactions. The questions will be responded to by the presenters at the end of the session. And before you ask me, yes, the event is not yet on the PPB portal. Once it's on the PPB portal, you will receive an email to remind you to subscribe, after which you will receive another email with the tokens to allow you to claim your CPD points within 7 days. Okay. And I hope that is correct. Lydia, I hope I have responded to your question. It is now my absolute honor and pleasure to introduce our guest speaker this evening, Dr. Mariciana Onono, who is a senior principal clinical research scientist at KEMRI. She holds both an MBCHB and an MEd from the University of Nairobi and an MSc in clinical research from the University of Liverpool. Also a PhD in global health sciences from the prestigious University of California, San Francisco, UCSF. Beyond her academic credentials, she has built a remarkable career spanning over 17 years, during which she has been at the forefront of medical advancement. She has successfully led nearly 40 implementation science and clinical trials and has contributed extensively to global medical literature with over 100 peer-reviewed publications. Her expertise in clinical trials, public health, and implementation science makes her the perfect authority to help us navigate the evolving role as pharmacists in defeating HPV-related cancers. And as Dr. Mariciana is preparing herself, I see we are above 1K. I would like to ask you to look through your screen. There should be a poll that has popped up. I want to encourage all the 1,000 of you to respond. This will form the basis for the presentation tonight. Very easy 4 questions. I see we have two answers, 8, 11. Let's take it up to 1,000. Very curious to what you are doing. The first question is, do you currently recommend the HPV vaccine to eligible patients? I know accessing the poll might be difficult if you're on your phone, but just look through where you would normally raise your hand. Do you feel comfortable discussing the benefits and safety of HPV vaccine with adult patients? Again, I encourage each and every one of us to interact with the poll. Yes, I see Janet has found the raise hand button. Just look again, you will see the poll. Maureen, also please interact with the poll. Do you believe pharmacists have an important role in increasing adult HPV vaccination uptake? Anyone who is yet to access the poll, I see we have 300 responses so far. It should pop onto your screen. Okay, just a few more minutes. I see we are almost halfway. Allow me to just read through the names I see here, just in case you have raised your hand instead of filling the poll. Janet, Libuna, Rono. Let us strive to respond. We are at 400 now. I see majority have actually recommended the HPV vaccine. Out of all who've responded, 90% have recommended. Also, majority feel comfortable discussing. I see I don't know who are these 2%. Maybe they can tell us in the chat or at the end why they don't believe we have an important role in increasing HPV vaccination uptake. Curious, but majority again feel like pharmacists have an important role. There goes the interesting question. Do you actively vaccinate in your pharmacy? Again, majority is no. very curious as to why that is the case. I hope, Dr. Mariciana, you can see through, and whenever you're ready, I the audience is ready for you. The floor is yours. Meanwhile, I will let it run for a few more minutes as you prepare to come in. Karibu sana, Dr. Mariciana.
Thank you. Thank you very much. I was not able to see the answers, but I am hoping that my presentation will move you towards more the currently recommending, feeling comfortable discussing, and being able to actively vaccinate wherever you're based.
Okay, I'll share in a few. I see in our members are still responding, but you may proceed as we engage with them on the poll. Yes.
All right. Can you confirm that you can see my screen?
Yes.
Uh, Great. So I will be presenting on the evolving role of pharmacists in adult female vaccination against HPV-related cancers and diseases. As I was introduced, my name is Dr. Nono Mariciana, and I'm a senior principal clinical research scientist working with KEMRI, and I've been the country director and co-PI on the Kenya single-dose HPV vaccine study. These are my disclosures. I have received funding from Merck for an investigator-initiated study to conduct an oral HPV study among men in Western Kenya. I know that in this particular presentation, we'll be focusing on female, but there is a big role of HPV as well, HPV vaccination among men, and I hope that this is something which perhaps in the future we can begin to highlight and to push for a more gender-neutral vaccine. I also had funding for other studies on oral HPV, as well as speaker fees for a medical education program on the role of healthcare workers. This will be an outline of my presentation, just taking you through the HPV burden, the evidence for adult HPV vaccination, the efficacy status that exist, what are the current vaccination guidelines, what is our progress towards the WHO 90-70-90 targets, what is your role and how we are able to address the patient concerns, so that hopefully you'll be feeling more comfortable at the end of this presentation, as well as the potential models in Kenya. And that would probably be more of a discussion rather than me prescribing, because you are the wearers of the shoe, you probably know what best would work. So I'm going to start with the problem. And the problem that we have is that HPV accounts for about 5% of all cancers globally, with cervical cancer making up 85% of these cases. The HPV 16 and 18 types alone cause about 70% of the cervical cancers, which really underscores their high carcinogenic potential. Other cancers, including anal, vulvar, vaginal, penile, and head and neck, are also significantly linked to HPV. And so it's not just cervical cancer. And this reinforces the issue that HPV vaccination and early screening are vital, and not just for women, but also for men, even though the presentation today is focusing on women. In terms of the natural history, we know that HPV infects the basal epithelial layer through microtrauma during normal tissue repair. And while most infections are going to clear naturally, persistent infection with high-risk HPV types leads to the genetic instability. There is the viral E7 protein, which then disrupts the cell cycle control and drives abnormal growth. Importantly, and I think what's most important for us, that the progress from HPV infection to cancer takes up to 10 years, which gives us quite a bit of time to be able to interrupt progression to invasive cancer. And I will be highlighting this more even as we go on in the presentation. The story of cervical cancer is a story of inequity. Cervical cancer is the fourth most common cancer in women globally, but the leading cause of cancer death in low and middle income countries. There are over 600,000 new cases and 341,000 deaths actually occur annually. But if this mortality, if you look at it, really varies very sharply. If you look at the figure there, you can see that it averages from about 1 per 100,000 in Switzerland to over 55 per 100,000 in Eswatini. And these inequities that we see reflect limited access to vaccination, to screening and treatment, which really speaks to the importance of health system strengthening. When we look at the Kenya-specific data, we have a population of 16.8 million women aged 15 years and older who are at risk of developing cervical cancer. Every year in this country, 5,236 women are diagnosed with cervical cancer, and about 3,211 die from the disease. Cervical cancer ranks as the second most frequent cancer among women in Kenya and the second most frequent cancer among women between the ages of 15 and 44 years. And about 9.1% of women in the general population are estimated to have a cervical HPV type 16 and 18 infection at any one particular time. And this data just tells us that we really need to, there's an urgent need for prevention, vaccination, and screening, particularly for women who are aged 15 to 44. I'll now take us through the adult women and demonstrate how women continue to have lifelong HPV risk. So this graph is basically showing that HPV infection occurs across all age groups, not only in adolescents. Our vaccination program has focused on the 9 to 14-year-olds, but HPV continues to occur across all age groups. We consider the highest risk is truly in the younger women between the ages of 15 to 24. So you're looking at the green line as well as the yellow line. But however, we see that even women who are 45 years and above, the purple line at the bottom, remain at risk, emphasizing that HPV is not just limited to early sexual activity. And this data actually supports the need to have lifelong prevention strategies, including vaccination catch-up and continued screening. When we look at this slide, we see that the risk of progression from carcinoma in situ and CIN1 to CIN3 or invasive cancer rises with age. Women who are over 30 years have a 7-fold higher risk of progression when compared to those who are under 20. And this suggests that persistent HPV infection in older women is more likely to cause precancerous lesions when compared to the younger women. And therefore, regular screening and timely management are critical for women who are over 30 to prevent invasive disease. I'll now pivot to talking about the HPV vaccine efficacy in adult populations. You guys are the gurus, but we do know that the HPV vaccines are made from virus-like particles, what we refer to as VLPs, that cannot cause infection with HPV or cause cancer. These HPV vaccines produce a much better immune response than the actual HPV infection. And this is just a factor of the VLPs in how they are designed. They are highly immunogenic. They are able to induce high concentrations of neutralizing antibodies, mainly because they are able to activate both the innate as well as the adaptive immune response systems. And they're able to remain high over time. Their response is basically very heterogeneous and polyclonal, unlike the natural infection with HPV, which makes them extremely efficacious. So why adult vaccination matters? We know that without vaccination, more than 84% of sexually active individuals are likely to acquire HPV during their lifetimes. We also know that adults aged 25 to 49 remain at risk of high-risk HPV infection, which supports the benefit of vaccination beyond the adolescents, as I've presented in the figures before. We do know that the quadrivalent HPV vaccine has shown really high efficacy of about 89% against persistent HPV infections, as well as genital lesions in women who are aged 24 to 45. And I will be presenting more data on that. We also know that lower vaccine coverage in younger population increases the potential benefit of vaccination in mid-adulthood. We also know that awareness is low, and this is where you come in. Only about 38% of adults know HPV vaccination is approved for ages 27 to 45. And I think, Miles, it would have been good for you to probably add that question to see how many providers are actually aware of this. And we do know for a fact that lack of provider recommendation is the most commonly reported reason for not being vaccinated among adults who are eligible. Currently, there are about 8 licensed HPV vaccines worldwide. 5 have received WHO pre-qualification and are available globally. In Kenya, we talk about 3. We have the bivalent vaccine, which protects against high risk, the oncogenic HPV strains, type 16 as well as 18. Then we do have the quadrivalent vaccine, which covers type 16 and 18, as well as against genital warts type 6 and 11. And then we do have nonavalent vaccine. We've mainly used it in the research setting, such as where we have been in Kisumu, Thika, Nairobi. And there are some providers in the market who are already providing this nanovalent vaccine, and it has the broadest protection against type 16, 18, 31, 33, 45, 52, 58, as well as type 6 and 11. National schedule, the vaccine may be given as 1 or 2 doses, actually 3 doses, and I'll be getting that depending on the national guidelines. People living with HIV ideally receive 2 or 3 doses for adequate protection. And there has been a push towards single dose adoption, particularly within the public sector, but the rollout has been low. For our country, the HPV, when you look at the HPV types in Kenya, which cause cervical cancer, we see that type 16 and 18 account for most cervical cancers. So type 16 has about 38%, type 18 has about 25%. But we also see that types 35, 52, and 31 also contribute significantly. Now, the quadrivalent vaccine, Gardasil 4, covers type 16 and 18 for cancer prevention and adds type 6 and 11, which protects against 90% of the genital warts. And this broader protection has visible gender-neutral benefits, so preventing diseases in both men and women and reducing transmission. And so for now, while we are waiting wider access to the nanovalent vaccine, the quadrivalent vaccine offers the most practical and comprehensive option for Kenya's HPV landscape. If we drill down more to the quadrivalent vaccine, this vaccine remains highly effective even in mid-adult women aged up to 45 years. We've seen that if you look at the slide, basically the clinical trials and the references are at the bottom. You can see the clinical trials show 89 to 92% efficacy against persistent infection and precancerous lesions within the first 4 years, and that long-term follow-up confirms 100% protection against HPV-related CIN and genital warts up to 10 years. And this evidence therefore supports catch-up vaccination for adults, those ones who missed, when they were kids, and I guess that's all of us here, and particularly those who are at least at risk of new HPV exposure, who I guess are all of us here again in this meeting. There's a common question of whether the chances of a woman being infected with all the 4 types of HPV included, and actually the likelihood of a woman being infected with all the 4 HPV types targeted by the quadrivalent vaccine is extremely, extremely low. It's less than 0.5%. This means that over 99% of women can still benefit from vaccination even if they've had prior HPV exposure. And this data is consistent across the younger 16 to 26, who you see on the left, and the older 24 to 45 years on the right. And this still continues to reinforce the fact that HPV vaccination remains beneficial for adults and not just those who are sexually naive. I put this slide here just to re-emphasize the fact that there's benefit in vaccinating people who've been previously infected, even with high-risk HPV. There's been a growing interest within the field of what we call peri-treatment vaccination, so being able to vaccinate before, during, or after surgical ablative treatment. The evidence we have is that having history of HPV infection, high-risk HPV infection, it is type 16 or type 18, does not preclude you from getting the vaccine. We know that individuals remain at continued risk for subsequent lesions even after successful treatment. And the risk persists for both the same. If you were infected, for example, with type 16, you can still get a type 16, or you can get a different type altogether. And so what these vaccines are able to do in vaccinating around in these individuals is the prevention of new infections from different HPV types, which have not been previously encountered. It also protects against reinfection with the same HPV type after you have cleared. It also reduces the risk from new exposures, and it prevents auto-inoculation from adjacent or distant infected sites. So what I'm trying to say here is that if you have been infected with HPV type 16, you can still have the vaccine because it will prevent you from getting reinfected with HPV type 16 and or other types. Remember, the persistence of the high risk is what leads to to cervical cancer. The limitations of this vaccine is that these vaccines work preventive. They're prophylactic. They're not therapeutic. And so they cannot clear an active persistent HPV infection. They cannot eliminate, any unresected HPV-associated dysplastic tissue. So if you didn't resect all of it and there's remaining HPV infection there, it cannot eliminate that. And they also cannot provide therapeutic treatment for existing infections. And I think I have lost my arrow for my grid for moving. All right, so now I will move towards the recommendations for females. Vaccination scheduled by age, so 9 to 14 years, we do 1 to 2 doses. Within the Kenya guidelines, we've moved to 1 dose in the public sector. We continue with the 2 doses in the private sector. For young women between the age of 15 to 20 years, we do 1 to 2 doses, and this is just aligned with the WHO, which supports reduced dose schedules. For women aged between 21 to 26 years, we recommend 2 doses. For women above the age of 27 to 45, we recommend 3 doses. For anyone who's immunocompromised, and that includes HIV positive of any age, we recommend 3 doses. And for vaccines that are approved for females, again, and as I said, we have the non-valent, we have the quadrivalent, we do have the bivalent. There's something that we refer to, which is known as shared clinical decision making. And this is basically where you engage the woman or the young girl in front of you. And the engagement here is not regarding whether to vaccinate, but really it's not really it's not a question of do you need the vaccine? It's a question of you do need to vaccinate the woman. I put this here just to align us and to let us know the MOH policy framework, what the guidelines say. There are 3 major guidelines. We have the Kenya National Immunization Policy Guidelines of 2023. So the HPV vaccine is included in the Kenya Routine Immunization Schedule. It targets girls aged 10 to 14 at public health facilities, and this is nationwide. We are doing single dose following the November 2025 transition from a 2-dose schedule. It's free of charge at all public health facilities, and we also have delivery through school-based programs and health facility outreach. And this is overseen by the ENVI program, and the counties do the implementation. Then we also have the National Cervical Cancer Elimination Action Plan, which is aligned with the WHO's 90-70-90 targets by 2030. Pillar 1 is to vaccinate, with vaccination, 90% of girls vaccinated against HPV by age 15. Pillar 2 is on screening. Around 70% of women should be screened by ages 35 and 45. And Pillar 3 is around treatment. So 90% of those who are screen positive or diagnosed women should be treated. And then we also have the NVISP 2023-2027 strategic plan, which really defines the medium-term immunization priorities. It speaks about Kenya co-financing obligation. As you do know, because we are now considered to be middle income countries, we then begin to graduate from graduate from the Gavi program, I think by 2027. And so that means that vaccine costs, Kenya has to meet the cost for the vaccines, 80% by 2026 and 100% by 2027. I do know that there are negotiations around this, but I don't think that has been finalized. It's anticipated that the single-dose transition will probably generate some cost savings, which can be redirected to catch-up campaigns, so allowing the girls who missed out on the vaccines to be vaccinated. And the goal is to really close the regional equity gaps. We know that some of, like, for example, the northern counties are lagging very much behind as compared to the national average. And this NVISP actually supports pharmacists and healthcare workers as last mile HPV champions. So you are considered within these particular guidelines. So a little bit more around this elimination strategy. We do know that this was launched by WHO in 2018. And the target, I think, as we went through, was that 90% of girls fully vaccinated by age 15, 70% of women screened at least twice in adulthood. And then we also have 90% of those with disease receiving treatment. And this strategy is integrated. So it links prevention, early detection, and care. And so it does require that we have collaboration across immunization, across reproductive health, and across oncology services. And achieving these targets could actually make a cervical cancer be the first cancer ever to be eliminated through vaccination. So if Kenya were to meet these targets by 2030, then cervical cancer could be eliminated as a public health program by 2120. I don't know whether we shall all be here, but our generation or our progeny will probably be here. And achieving this would save about 1.9 million lives over the next century. And the largest impact, as you can see from the in blue, will come from vaccination. Vaccination alone will contribute over 70% of deaths averted. And so this just really underscores the importance of investing in HPV vaccination as well as screening, because screening alone, and as I will show in the next slide, vaccinating alone will not take us there. We need a combination. So this is modeling data. And this modeling data is just showing what I've been explaining, that combining HPV vaccination with screening delivers the largest reduction in cervical cancer deaths. By 2030, mortality could fall by 1/3, and by 2120, up to 99%. So towards the end of this graph, of deaths could be averted. And vaccination alone has impact, as I said earlier, but adding lifetime screening and treatment dramatically accelerates that elimination. And so given the current status quo, where we are, without elimination scale up, the rates would stay at the current high rate of about 13 per 100,000 per annum. And the line at the top here is basically showing that is demonstrating that. And so we do need a comprehensive, integrated approach to be able to attain this elimination. So now I'll come to us as pharmacists, your role evolving from just a dispenser to a counselor to vaccinator, and as well as an access point. There is global evidence as well as local evidence from Kenya to show that there is high acceptability of pharmacy-based delivery. In our studies done in Kisumu, we saw that 96% of Kisumu pharmacy clients like the model of pharmacists being able to deliver HPV vaccine. 93% did not expect it to be hard to obtain, and this sample size was of about 1,500 people. In Canada, we do know that 91% of adults under the age of 25 would accept the vaccine if it was publicly funded. The willingness fell sharply once they were asked to pay. And looking at the Middle East, the UAE, 68% of community pharmacists were willing to vaccinate if regulations allowed, and 82% would complete the training. So looking at it, and especially looking at our Kisumu data, you can see that more than half the clients were planning to vaccinate actually preferred a pharmacy, and that pharmacies expand choice. They do not replace clinics, because sometimes people feel that in moving into pharmacy, then what will the clinicians be doing in the hospitals? But what it just does is that it expands choice of where to access this particular to get this particular vaccine. So I need to move that up. So what gaps would be the pharmacists closing, and why do adults miss out on the vaccine? The main barriers that we see is low awareness. Many adult women are unaware that HPV vaccination is recommended beyond adolescence. We all assume that it ends in adolescence, and once we have been missed, we have been missed. There's also no provider recommendation, and throughout literature, we see that this is the number one cited barrier. There's just nobody to recommend this particular vaccine. And yet we know, for example, the pharmacists see patients far more frequently than physicians. There's also the issue around stigma and moral judgment. HPV vaccine has been linked to sexual activity. And in focus group discussions that have been done, most people cited fears around, being seen as promiscuous. And pharmacies in themselves offer private, non-clinical access, and so remove that stigma of somebody going into a health facility. There's also the aspect around the perceived cost. Of course, it's been seen to be a barrier. You saw in the earlier quote from, I think it was from Canada. And we do know that right now, as the field is evolving, that pharmacists may be able to navigate some of these insurance and patient assistance schemes. The other thing, of course, is around limited healthcare access. We think about our doctor-patient ratio. It's pretty high, and pharmacists, especially in the community, are usually vastly more accessible, especially in the rural and in the northern counties. On the top there, I just provided metrics around, the fact that it's just slightly, a little bit more than half of healthcare providers who are aware that they can make a recommendation for HPV vaccination for women aged 27 to 45 years. So why are we pushing for pharmacy-based delivery? There are four main advantages. One, improved access. It expands choice. But often we find that, pharmacies have long operating hours, and they have good weekend availability. They are also found in convenient locations, so accessible community sites which are embedded where people already go. And they're also an opportunity to reach individuals who missed routine HPV vaccination. And this is a scalable model for delivery of other preventive health services, even as Dr. Miles introduced. So what is the role that we envision? We envision that pharmacists can be educators. They can counsel patients and parents. They can do community education and outreach. They can do reminders and recall services. That pharmacists can also be vaccinated. They can do direct they can do direct vaccine administration. They can also do vaccine advocacy and promotion. And they can also be facilitators. They can identify missed vaccinations. They can help in updating the immunization records, and they can support vaccine safety monitoring. In studies that have been done, we've seen that pharmacist interventions increased overall immunization uptake by up to 51%, while the frequency of immunization doubled when pharmacists acted specifically as administrators. So moving just from beyond educators and counselors and recommenders to moving towards being vaccinators, we are able to increase our immunization rates. And for studies done in Canada, we saw that they had increased coverage rates when pharmacists were vaccinators, especially for vaccines such as the influenza vaccine. A common barrier, I think I already mentioned this, to address is the knowledge gap among pharmacists themselves. Issues around limited awareness of HPV and HPV vaccines. Issues around the relationship between HPV and cervical cancer, knowledge gaps around target vaccination age, knowledge gaps around recommended dosing schedules. And I think this is why we are having this sort of like sessions just to create awareness and increase that particular knowledge. In terms of implementations and what we would do as a country, I think that there is room to develop pharmacist vaccination training programs. I'm aware that there is one which is offered by the University of Nairobi, and to be able to take that up, I don't know how many of our pharmacists have taken up these training programs. Two would be to increase public awareness of the competencies of pharmacists in providing immunization. Three would be to strengthen physician-pharmacist collaboration so that when people even begin, and you will see it in one of the models that we are proposing, when begin their vaccination within a health facility, that perhaps this could just be completed within the pharmacist. There could be more advocacy by pharmacists regarding third-party reimbursement mechanisms, because we do know that this the cost has been a barrier, especially in our setup, and also improve care coordination and vaccine tracking systems. Looking at studies which have looked at this, for example, in Hawaii, physicians interviewed on their willingness to send adolescents to pharmacists who are actually very willing, and they were able to pass legislation to allow pharmacists to vaccinate for adolescent vaccines, with the potential to increase access and opportunities for patients to complete the HPV vaccine series. So I'm hoping that this is something that we too would be able, in the long run, to advocate for. So moving on to counseling, how do we talk about, there's a question around being comfortable discussing issues around the HPV vaccination. When it comes to counseling, we need to avoid complex scientific explanations. We need to use short, clear sentences that patients can relate to. Make the message personal. For example, the vaccine protects you from cervical cancer in the future. So it really should not be long. It should be like an elevator speech. Short and succinct, and talk about your own experience. So when I am counseling, for example, for the HPV vaccine, I like to mention that, I got vaccinated at the age of in my mid 30s, and I was still able to get my child, so it does not even affect our fertility, as people talk about it. So I think being able to be personal and emotional about it also opens up for people to be able to take up this vaccine. Then ensure the right choice of words. So use empowering and positive words like protection and prevent cancer. Avoid terms that stigmatize, such as promiscuous, or complicated terms like immunity, like what we are using right now. So keep the language simple, keep the language supportive. Patients inadvertently are going to be concerned about safety, of this particular vaccine. And so how do you provide this assurance? We know that the quadrivalent vaccine has one of the most robust global safety records. There have been over 300 million doses that have been dispensed worldwide. And it has been independently reviewed and endorsed by leading regulatory and scientific bodies, including WHO, FDA, EMA, CDC, you name them. They have reviewed. And the Global Advisory Committee on Vaccine Safety has also reaffirmed that there is no evidence linking HPV vaccination to infertility or even to premature ovarian insufficiency. And so this broad global consensus should be able to reinforce the trust and confidence that we have in the HPV vaccination as a critical public health tool. Patients might also be concerned that the disease happens later in later stage of life. Does this vaccine have lasting effectiveness? Do I need a booster dose? And the evidence is that the quadrivalent vaccine provides sustained protection for over a decade. In women aged 24 to 45 years, the studies have found no breakthrough cases for HPV vaccination, vaccine type 6, 11, 16, or 18 related CIN or genital wards, even after 10 years of follow-up. I think there are very few vaccines, if any, with this kind of a track record. And this demonstrates durable immunity and long-term effectiveness, reinforcing the value of vaccination beyond adolescence. So you really should have confidence. There also may be concerns around delayed vaccination. Nilianza nikaacha. I started, I forgot. If you look at the statistics, for example, in Kenya, you see the first dose is very high, but the second dose is very low. So do we restart the series or what do we do? So the HPV vaccination schedules are highly adaptable, and interruptions do not require restarting the series. There's also no maximum interval between doses, which allows for these programs, vaccination programs, to continue even after long gaps. The evidence shows that 2 doses within 3 years or 3 doses within 1 year still remain to be effective and to provide comparable immune protection. And so this flexibility makes HPV vaccination to be very feasible in real world settings, especially where follow-up or access may be delayed. And I'd encourage you to read the article there to support this particular evidence. So in terms of delivery models, and don't worry, I'm about to finish. I think that there are 4 delivery models which we can consider as a country. One would be coordinated clinic pharmacy, where a clinic can give dose 1 and then refers to a partner, pharmacy for the rest. And this has been rated favorably by staff, but completion is the weak link to be able to engineer this out. You can also have rural access provider, where you can enroll a rural pharmacy. It really doesn't need to be a rural pharmacy. Just because I work in Kisumu and its environment, so I'm hung up on the rural bit, to be a public vaccine provider. And this is able to tackle the issue of cost and distance directly, especially for undeserved population. And then we can also have pharmacists administered. So having that the pharmacist to be able to do the actual vaccination, so in parallel to the clinicians, and then to also be able to do the catch-up vaccine. So while the public health programs are focusing on the 10 to 14 years, there is a role for pharmacists to extend this to the girls who missed, and to the older age groups all the way to 45 years. Of course, there are challenges, issues around costs and financing this vaccine. It's very, it's highly acceptable, but it's costly, So I think knowing how to address when people have to pay for this out of pocket. There's the issue about series completion. However, as I just said, that the scheduling for this vaccine is very forgiving. It doesn't need to be, within within 1 year, that people can still have intervals between the doses. There's also the issue around regulatory scope. So expanding pharmacist vaccination may need PPB and Ministry of Health enablement. And then there's the aspect of training and confidence. But I think that this is something which is addressable through structured continued professional development. There is an opportunity for us, whether you're in the public or in the private sector, but if I was to focus on the private sector, the private sector already has infrastructure in place. Private sector has offered HPV vaccines since 2006, even before it became in the public domain in public. And you guys have established cold chain and delivery systems. As we've demonstrated, there's high client acceptability for for clients to receive the HPV vaccine within their pharmacies. There's also a willing to pay market. Even in the studies that we did, we've seen that 90% of pharmacy clients who are willing to pay, especially the young adults who missed the free program. And there's an opportunity to integrate and sustain this. So being able to link with reproductive health services and screening, to counter misinformation and to build affordable pricing. So as I wind up, I think that my recommendations are at two levels. For the individual pharmacists, I think just to recommend HPV vaccination at every relevant encounter presumptively, to actively offer catch-up vaccination to adult women who missed the program, and also young girls who missed the program, to keep your myth-busting answers short, calm, and evidence-based, and to link every conversation to cervical screening. As we said, vaccination will take us 70%. Adding on cervical cancer screening takes us further along. And for PSK and the profession to be able to engage PPB and MOH to formalize pharmacist administered vaccination, to build accredited HPV vaccination training into your CPDs, to pilot coordinated clinic pharmacy referral designed for completion. I'm a researcher, so I'm constantly thinking about research around these things. So I think this is something which you guys could be able to pilot, and to be able to advocate for affordable tiered adult pricing and financing. So, well, the burden is heavy, but it's preventable. Remember that women can still benefit from this up to the age of 45. You guys are able to, you're pivotal. You're very accessible. You can cancel, you can vaccinate, you can do the catch up, you can refer. So there's a huge role for you. And that this model of pharmacy delivered or pharmacy canceled or pharmacy, follow up is highly acceptable. Thank you. Over to you, Dr. Miles.
Thank you so much, Dr. Mariciana. And as I share in the comments of Alex Ogola, who says it's a very insightful presentation. And just so we don't lose out on the content, I want us to jump straight into the Q&A. Dr. Mariciana, when you look below your computer, you'll see a Q&A tab. I don't know whether you can be able to access it. Or should I go through the questions and direct them to you?
Apologies, I had muted myself, but yes, I can see. I can see. So I'm seeing the question that among the three types, bivalent, quadrivalent, nonavalent, which one is the single dose? Single dose just basically means that you're giving one dose. The bivalent, quadrivalent, and nonavalent are the types of HPV vaccination. Single dose is just the number of doses that you're providing. So in Kenya, there's been a pivot in November to the single dose within the HPV, within the public sector, in the younger age groups of 10 to 14. So WHO has recommended that you can do the single dose, but from the ages of 27 upwards to 45, we are going for the 3 doses. Between the ages of 15 to 26, we are doing 2 doses. The second question I see is that can you recommend HPV vaccine on a lady in early 40s who underwent myomectomy that led to menopause. Yes, of course. Up to the age of 45, we are recommending that you do have the HPV vaccine. As I showed you, that even women above the age of 45, I had a slide which was showing you that they were still prone to getting HPV infected, and so there is value in your early 40s up to the age of 45. I know that there are extended studies trying to see if this can be extended all the way up to 56. So there is value in getting vaccinated. So please do get vaccinated, Maureen. The second question is I think is also related to the other one by Gladys. Can someone be vaccinated after 45 years of age? There are countries which are actually vaccinating beyond the age of 45, but this is more off-label. As we get evidence regarding the effectiveness beyond that particular age. James Angima, why do medics administer HPV vaccine to eliminate cervical cancer, but on the other hand, administer hormonal contraceptives that are linked to cervical cancer? I think the short answer of that is that one particular being can have many needs. But I do believe that during the prescription of selection of contraceptives, that women are informed regarding their choices and some of the adverse events that might occur with some of the contraceptives. The important thing to remember is that if you have that the vaccine is prophylactic, that it does prevent you from getting the HPV vaccine. Getting the HPV virus, persistent HPV, for luck, yeah. Dr. Michael Mungoma, HPV-16 is reported as a high-risk strain affecting men also. As much as men clear HPV naturally, are there studies in Kenya completed or ongoing supporting possible cancer occurrences in men associated with undiagnosed men? I think, as I said at the beginning, that HPV-related cancers, 16 and 18, do not just affect the cervix. We are seeing an increase in oropharyngeal carcinoma related to type 16 and type 18, whether it is with men who have sex with men, or even as people just become adventurous in their sex life. And what we are actually hoping that the future would be a gender-neutral vaccine. In the developed countries, in the high-income countries, this vaccine is administered to both men and to women. In the earlier presentation that I did to the clinicians, we actually advocated and provided the vaccine schedules for immunizing the men. So this vaccine can be offered to men up to, I believe, the age of 26, and it is recommended. I think the reason why it is not here is mainly a cost issue. It's not an efficacy issue. It's mainly a cost issue. So for those who can afford, we do recommend that, vaccinate your boys, vaccinate the men as well. So early sexual exposure in young girls is a predisposing factor in cervical cancer. Why do medics not emphasize to girls against early sexual exposure, but emphasize HPV vaccine? Does it mean that the HPV vaccine will protect a girl that starts sexual activities early? The HPV vaccine protects you regardless of whether you have early sexual debut or late sexual debut. I think the issue around, if we remember during the early, it wasn't Trump, I believe it was George Bush. When George Bush came into power, he was anti-contraception and he pushed for abstinence as a strategy. And if you do remember, in looking even at the statistics of Kenya at that time, where we began preaching abstinence and even stopped providing things like contraception to this particular age group, there was an increase in teenage pregnancy, there was an increase in abortion. I believe, and maybe I am biased, that that narrative, we preach it in church, we tell it to our children, but I think that times have changed and people are still engaging in sex at whatever age they are. And so that even as we talk to people and tell them to delay, to our girls, and ask them to abstain or encourage them to delay sexual debut, we do know that it's ongoing behavior, and that it might take time or may never change. And so I think our recommendation would just be that from the age of 9 to 14, we do know that the vaccine, initially, the early studies were showing that it works very well among people who have not had sexual encounters, mainly because of the high immune response. But if you look at the data from Kenshi, which we did in Kenya, and uh, we compared the efficacy of this vaccine in the 9 to 14 age cohort, as well as ours who had begun sexual debut 15 to 20, they were actually comparable. So there was actually no difference on that. So if you've done DNA, HPV test is negative for 16, 18, 16, 28, I think you meant 14, 18, 45, but positive for others. Can you get the vaccine? So, even if you have been infected with HPV, the oncogenic type 16 and 18, 16 or 18, first of all, as I presented, it's very rare, less than 0.5% for you to have all of them, you know. And even if you had one, there is benefit to be protected from the other ones which you didn't get because you can get reinfected. If you had 16, you can still get 18. So there is value in getting immunized, even if you've had one of the high risk HPV types. So whether you've had your 16 or you had your 45, if you've had your 45, of course, the Gardasil 9 would be good because then it's able to protect you against the type 45. 28 is not typically considered to be high risk. I think you meant 18.
Dr. Mariciana, maybe
Yeah.
I can also just chime in and help you. There's a question from Christine Kajumbi, right at the bottom. She says, "Thank you for the informative presentation. Would you consider expanding on the management of cervical cancer, particularly the surgical treatment options for advanced disease?" She thinks it would be valuable for the audience to understand that treatment can involve extensive procedures, including the removal of the cervix, uterus, and its surrounding tissues, and in some cases, even part or all of the vagina or other pelvic organs, highlighting the potential physical and emotional consequences of advanced disease, I think.
Yeah, I think that's a whole different presentation in itself. Yeah, but depending on how invasive, what stage of the cancer it is, whether it is CN1, whether it is, or whether it is advanced, the treatment can range from just ablative therapy. You can end up having excisions, or you might end up actually having like total hysterectomy with, complete total hysterectomy plus BSO. And of course, as she says, that it can be very associated with a lot of morbidity and mortality. And so I think that we really do not want to reach towards the treatment. We are trying to prevent the cancer, but that's a whole different presentation. And I'm happy to invite, I think, Professor Nelly Mugo, who we work with, who has done quite a lot of work in that space in Kenyatta National Hospital to talk about it if it's something of an interest.
Thank you. Thank you, Dr. Mariciana, for that. Maybe we can take one more question. Gladys asks whether there is need to repeat the vaccine after 10 years.
No.
Kindly elaborate on that. Thank you. Gladys, the answer is no. Yes. Do you have anything else to add, Dr. Mariciana?
No, 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 you do not need to extend. So the data that we presented was what was published. But if you want to look at it, there are studies from Australia, from Canada, from Norwegian countries. There's one even recently from the UK, which shows that over time, I think it's been a period of about over 20 years of follow-up, where people who were actually vaccinated to date, have not developed cervical cancer. So you do not need to repeat this vaccine. It's highly durable. We call it durability. It's highly durable and it does not wane.
Okay, okay. Thank you so much. I see we also have a few questions on the chat. I'll try see if I can get any. There's a comment from Coloni that this should be included in the curriculum for pharmacists so that they can qualify to administer within their scope. Trying to read through.
There's one I
Uh,
see here about for those who are already sexually active, what is the recommendation? Whether to give vaccine after HPV testing? No. You provide the vaccine
okay.
regardless of sexual activity. There's a question, I think, regarding the Kenshi study and how long we followed up. We are in year 8. We're in year 8 of follow-up for the Kenshi study. Yeah.
Awesome. Awesome. Thank you, Dr. Mariciana. At this point, I see there's a lot of engagement on the chat. Maybe even as we try and get to the closing poll, I'd like for our members and participants to maybe just type in what have you learned today, and a poll will show up on your screen. I would encourage each and every one of us to engage with it. Thank you, Dr. Nono, for the masterclass. A round of applause from PSK and for the eye-opening presentation. Dr. Mungoma has challenged us to take up the proposal to train pharmacists to administer safe and effective HPV vaccine. I think it's a conversation we can have beyond this webinar tonight. And just a reminder that there is a poll that has probably popped up on your screen. Do you now intend to routinely recommend HPV vaccine to eligible patients? Majority of the participants agree, and they feel comfortable discussing the benefits. We've been given a snippet by a response to Dr. Kajumbi's question by Dr. Mariciana of how treatment for advanced disease is like. So prevention would be preferable. Do you intend to actively vaccinate? I see yes. And at this point, as we draw this session to a close, just a recap, okay, from a few things and a few notes that I was also able to take. Thank you, Dr. Mariciana. You've left us with 4 key truths that we need to take back to our practice and think about is the burden is heavy, but it is entirely preventable. Let's think about that. Adult women would still benefit. We as pharmacists are absolutely pivotal because we are uniquely positioned to counsel, to catch up, to vaccinate, to reassure, and even to refer starting today. And the pharmacy model is very acceptable both globally and here in Kenya because of improved access. There is convenient location of pharmacies, and it's very scalable also. And for you as an individual pharmacist who has listened through this webinar, uh, we encourage you to actively offer catch-up options to adult women. You recommend the HPV vaccination. And also, Marciana mentioned that talking about the HPV is like an elevator pitch. Keep it calm, concise, and evidence-based. We as PSK, we are going back to our drawing board to actively engage with PPP and MOH to formalize and solidify the pharmacy-based administration of the vaccines. And thank you to Dr. Mariciana Onono for that. At this point, I would also like to thank our partner MSD for supporting this. And I see there are a few of them as the panelists. Thank you to to Silas Njiru. Thank you, Tabiso. Thank you, Kabelo. And just before we close, again, a reminder to engage with the poll. I've seen a few concerns about CPD. Once again, the event is not yet on the portal for those who are asking. Once approved, I will send an email to each and every one of you to subscribe, and also together with tokens that you'll be able to claim within 7 days. At this point, maybe just allow me to share my screen and um, give a few announcements. I promise you, it's just one announcement that I assume most of our participants are community pharmacists this evening. There is an opportunity for you about an ongoing project within Supply Health called the Optimizing Pharmacy Channel. If you practice in Uasin Gishu County, Nairobi, Kajiado, Kiambu, Nakuru, Meru, Kericho, Kisii, Kisumu, Machakos, Mombasa, you are welcome to join this MOH approved FP program. So for inquiries, you can write to projects@psk.or.ke. A unique opportunity to elevate your practice, improve access to reproductive health services, and position your community pharmacy as a leader in community health. And also see you on Thursday for our biweekly webinar with on asthma management device matters. We'll have a presentation by Bernard and Doreen. I will be your moderator. Looking forward to seeing all of you on Thursday, same time, same place. At this point, I don't have much to say. Those are my only announcements. And I see we are 15 minutes beyond the hour. If you may allow me to close so that I can go cheer for Spain, I would be happy. There being no remarks, thank you, Irene Muge, for the comments. And also, I see, yes, this webinar will be uploaded on YouTube. I don't have anything else. Have a lovely evening. Good night, everyone.